Good afternoon, everyone. Welcome to Medical Grand Rounds. Before we begin, I'd like to make a brief land acknowledgement. McGill University is on land which has long served as a site of meeting and exchange amongst Indigenous peoples. We acknowledge and thank the diverse Indigenous peoples whose presence marks the territory on which we now gather. Just a reminder to please leave your questions till the end. Please enter them in the chat as well. Please answer a brief survey that will be sent to you immediately after the presentation. This will let us know that you were present today. And finally, I'd like to invite the Chief of the Division of Palliative Care, Dr. Justin Sanders, to introduce our guest speaker today. Thank you. Dr. Sanders.
Thank you, Dr. Giannetti. Thanks to everybody for being here today. Happy Palliative Care Week. This is a great that we have this time in the Department of Medicine, to whom I'm grateful for the opportunity to share a palliative care speaker today. And because this is a week in which we are celebrating palliative care, I invite people to look out for the various lectures that we have throughout the week that are focused on palliative care. It is a really great pleasure for me to welcome Dr. James Downar to give today's presentation. Dr. Downar is a critical care and palliative care physician in Ottawa. He actually is returning home a little bit because he graduated from McGill Medical School and completed residency training, completed internal medicine residency training, as well as critical care training and palliative care at the University of Toronto. He has a master's degree in bioethics from the Joint Center for Bioethics at the University of Toronto. He's professor and head of Division of Palliative Care at the University of Ottawa, where he also holds a clinical research chair in palliative and end-of-life care. He's an adjunct professor at the Australian Centre for Health Law Research at the Queensland University of Technology, and is current president of both the Canadian Critical Care Society and co-chair of the Pan-Canadian Palliative Care Research Collaborative. He's authored more than 170 peer-reviewed publications and has been the principal investigator on more than $12 million of peer-reviewed grants on topics such as medical aid in dying, communication and decision-making in serious illness, palliative care in the critical care setting, grief and bereavement, and the treatment of psychological and existential distress in advanced illness. In 2024, he received the King Charles III Coronation Medal for contributions to palliative care in Canada. And in 2021, he received the Award of Excellence from the Ontario Medical Association section on palliative medicine. I will say that since I moved to Canada, Dr. Downar has been an incredible collaborator and support for me, very generous with his wisdom and projects. And so it's a real pleasure to welcome him here today. And Downar.
Thank you so much, Justin. And I really always an honor to come back and be here at McGill, where, again, I'd like to say come back here, but this building wasn't in existence when I graduated. Of course, I was in at the old Victoria and the Jewish, but again, familiar faces, and it's just so many wonderful memories here at McGill. And so I'm very happy to come back and talk about some of the work that I've been up to, along with a number of collaborators, talking a little bit about timely identification of patients with unmet palliative care needs. And so I'll just kick it off. So really just wanted to talk about, the importance of why do we need timely identification of patients with unmet needs, talk about some of the limitations of approaches that have been used in the past. Can everyone hear me okay? Okay. And then talk about some of the newer automated systems, and HOMR being the one I was going to focus on today. I've had grant funding from HOMR from a number of sources that I'll show. I am a paid employee of Ontario Health that relates to development of models of care in the hospital that are relevant to this. Just want to give a big thanks to all the different organizations that have funded the HOMR research over the years. We're very grateful for all that support. Of course, it would never have happened had that not been the case. So big thanks. Okay, so if you have to state the case for what we're up to here, sorry, I think someone's trying to get in the back door there. If you have to make the case for why I'm here talking about this today, in one slide, it would naturally be table 4B of an open access publication, right? So this is a really important publication for those obviously who have memorized it, like I have, Sen Xiao BMJ Open 2018. So this is looking at access to palliative care by disease trajectory. Of course, it isn't actually measuring access, it's measuring involvement of palliative care. And this sort of makes it, I think, very clear where we're doing well in the system and where we need to do better in the system. So if you look at people at the end of life and palliative care involvement in people at the end of life by their disease trajectory, that's what this table is showing. So terminal illness here is the first column, organ failure the second column, frailty the third column. You will note that approximately the same number of people in Ontario died following each one of these trajectories. That's well known, I think well recognized. And then here in each row, you see different measures using health services metrics of this. Now, we can spend a lot of time arguing and disputing about how accurate these metrics actually are. Let's just leave that to the side for now, because I'm trying to illustrate a point. If you look at people dying of terminal illness, and most of these are cancer, in fact, almost all of these people, or a very large proportion of these people, are actually getting some form of palliative care before they die. Many of them are getting it in the community, which is where we think most people should be getting palliative care, at least at some point. The median time between first encounter with palliative care and death is something in the neighborhood of 3.5 months, which is not a terrible standard if you have to think about it. In fact, many people are getting it for many, many months beyond that, right? And in fact, even your 75th percentile is getting it for more than a month. So those aren't terrible numbers from a palliative care perspective. And then they're not just getting it once, but in fact, approximately every third day, they're having some sort of encounter with somebody who could be justifiably considered a palliative care person. Okay, so that's terminal illness, that's cancer. Now, compare and contrast organ failure. So you immediately cut in half the proportion that are getting palliative care at any point. In fact, you cut by 3/4 the number who are getting it in the community. Instead of getting it 3 months before they die, they're getting it 3 weeks before they die, median. And instead of getting it more than every third day, they're getting it barely every fourth day. And then frailty, the numbers are even worse than that. So what we're finding is that palliative care, in particular timely palliative care, is actually, we're in cancer world, we're not doing that badly, but it's everywhere else where we're doing poorly. And if we're going to talk about getting palliative care integrated with people, it's fairly obvious where the emphasis needs to be and where the growth potential really is. It's not to say we can't do better in cancer, but there's obviously more important areas for where we should be doing better. Okay, so take a step back. What is the process of early identification or timely identification, right? So one of the things that comes out of work like the Gold Standards Framework in the UK is this sort of mantra. And everybody just say it with me. Identify, assess, plan, manage. Identify, assess, plan, manage. So it's important to break these down into different steps because they are all distinct steps, right? And they're all actually quite distinct processes required to do this, right? So you have to have a system where you're identifying people who might benefit from palliative care at that point in their illness trajectory. You actually have to assess them for the unmet needs, right? So the process of identification and assessment are often distinct processes. But then once you've identified things, you actually have to start to come up with a plan and then deliver on that plan. It's quite a complicated multi-stage process. We're going to get into it. So then the obvious question is, when is early? What is timely? Like when we say early palliative care, and you probably hear the term early palliative care a lot, but what exactly is early, right? So for those familiar with the bow tie model, Pippa Hawley's bow tie model, I'm a big fan of this, by the way, right? So you have this sort of disease management triangle here, which sort of slowly shrinks from right to left as time goes on. The pain and symptom management or palliative care sort of triangle that slowly grows from left to right. And then you have a consistent and heavy overlap in the middle. And patients who improve over the course of time, they go to rehabilitation and survivorship. And patients who do not go to palliative care and hospice, and then there's bereavement services, right? So at what point, where along this trajectory do you get early, right? Like early-ish, not early. Like it's understanding where that trigger point is actually becomes super important for how you structure services and how you deliver. Okay, so put differently, this is a famous poem by Piet Hein that Daniel Kane in Kingston referred to me. I love it. There's an art to knowing when. Never try to guess. Toast until it smokes, and then 20 seconds less. Pulling back from the poem, we are really good. Raise your hand if in the past year or 2 years you've been to an M&M rounds that was basically in some service or something that basically was concluded dude, yeah, we really dropped the ball here, man. This was a totally bad death and we totally should have had earlier palliative care. You know what? So as a go forward action item, do a better job next time. Do it earlier next time. Everyone's solid, man. Good plan, right? that is as helpful as, like, you all had a cheap toaster at one point in your life that didn't really work all that well and smoke. And then, like, you put the toaster in, it starts smoking, the smoke alarm goes off, and then you've got that pothead roommate who walks in, is like, dude, and like while you're like desperately fanning the toast and like opening the window and blowing it out, it's like, dude, I think you burned the toast, right? And it's like, he's not helpful. Like, I know, dude, I know, right? The key was not to be the pothead that shows up after there's smoke filling your kitchen to say that you burned the toast. The key is actually to have a toaster that identifies when the toast is done and pops it up, right? So really, this sort of retrospective, subjective, kind of retrospective judgmenty thing is just that's not a model for quality improvement, right? And it makes us feel good that we always decide we're going to do better next time, but we frankly don't. Of course, the literature will help us, won't it? I mean, everybody knows that scientists always agree on things in the literature. So it's fascinating. This is easily one of my favorite papers ever. Please read it if you haven't. Van Mechelen's systematic review, defining the palliative care patient. So mostly cancer, 60 RCTs. And all they did was look through it, like, how was a palliative patient defined in an RCT of palliative care? Published RCTs have no clear definitions of their palliative care patients, and there was a lack of consensus concerning the attributes of illnesses needing palliation and the ambiguous use of the adjective palliative. Okay, I love this. This is like, absolutely stinging kind of comments that you only get from the Dutch. So break it down into the arc, right? So neurologists in the room? Neurologists? Any no neurologist? That's a shame. Okay, so there's the afferent and the efferent limb of the reflex arc, right? And similar to the sensory and motor neurons of the reflex arc, you have sensory and motor neurons of the palliative care arc, right? So you have the sensory neuron, right? So you have your patient and family, and then there's a process by which you identify and assess who might have unmet palliative needs. That sensory neuron comes to the motor neurons here in the spinal cord. And then you have an efferent motor neuron that does the action and planning, like, what do we do about it? And you then deliver, and this arc continues to cycle around. The problem is that there are a lot of barriers to getting this arc to work properly, right? So identification and assessment processes are really undermined by healthcare providers who are overwhelmed. Like, unless these days, if you're on the ward, like, if it's not on fire, you're not dealing with it. Like, it's just not a thing that you really are going to put a lot of priority on. Sometimes they're underskilled. They don't actually have the tools to identify and assess those with unmet needs. Maybe they're unwilling. It's not my job. Don't you know how busy I am? The tools that they're using to predict and identify people are ultimately inaccurate. And then even when healthcare providers do identify people that have unmet needs, right, they may be overwhelmed. They just don't have time to deliver on it. They may be unskilled at communication or unfamiliar with treatment options. Sometimes the patients and families are actually unreceptive to the message, and maybe they misunderstand what you're trying to do. You may at times have no resources to deploy, although I find that excuse is used far too often around here, when in fact we probably do have resources. We're just not using them. And then, of course, you do this brilliant plan in the hospital, discharge the patient home, and nobody bothers to tell the GP. So ultimately, your sort of work is undermined. But if you're going to do sort of just break this down into these two sort of sections of the process, right? Like trying to come up with an identification method that is streamlined, that uses existing workflow, and that creates a manageable workload, right? So let's give an example of something that until recently was kind of standard and which is probably a little problematic, right? The gold standards framework, prognostic indicator guidance, or GSF-PIG tool that was recommended in the UK. A 3-step assessment process. It starts with a surprise question. Would you be surprised if this patient died in the next 12 months? Followed by some indicators, general indicators of decline, specific clinical indicators. All right. So problems with asking somebody if they're surprised. I don't know if any of you have the ability to be surprised by anything anymore. Personally, I have not. Like, since 2016, aliens arrived from the sky. It turns out we're all just cattle for them to eat. I'm like, yeah, I saw it coming. I really saw it coming. But the surprise question in medicine is actually was advocated for many, many years. And I think, just to be fair to those who came up with it, it was certainly an improvement. It was a good way to start. But we have to recognize the limitations of the approach, right? So we did a meta-analysis published in CMJ, High 10, and we looked at 16 studies, 11,000 patients. So how good was the surprise question actually identifying people, just to identify people who were in the final year of their life, for example? Actually, not that good. Sensitivity is not that great, since 67%. Specificity isn't terrible at 80%. But again, if you're looking for screening tools, it's really sensitivity that you're most interested in, right? So having a screening tool with a sensitivity of 67% is pretty poor. If you break it down to likelihood ratios for those, epi geeks in the crowd, right? So generally you like a positive likelihood ratio of 4 or greater. You prefer a negative likelihood ratio of 0.25 or 0.2 or less. So it kind of fails on both counts. Positive predictive value, 37%. So if somebody screens positive on the surprise question, only 1/3 of those people will actually die in the coming year, right? So you're sort of not particularly sensitive, but you're also getting a ton of false positives too, right? Now, if you focus specifically on cancer, you actually do get a likelihood ratio above 4, which is great. But then that means that in non-cancer, you're sort of trivially better than a coin flip, which is not great. Other problems with the surprise question. Kappa is poor to fair, right? So interobserver variability is quite high, particularly for non-cancer. When you send it out to like GPs and large groups of people operating in the community, you get really poor response rates. 10-15% of people actually bother to use it, even when they're prompted to use it, from some studies, right? So, and then there was, one of the big people, in Catalonia, northeastern Spain, they used the factor sorpresa. And the factor sorpresa, actually, in many people, GPs who have practices focused on the elderly, literally 83% of the people they screen come back positive. So, if you're screening, if literally 83% of the people who come in your door are coming back positive, you don't have a screening test, you've got a door chime, right? It's not necessarily helpful for you to focus your time and energy on people, right? So in fact, the surprise question's been dropped by NICE now. It's been dropped from the SPICT tool, which is another UK-based early identification tool. But then, okay, even if we take out the surprise question, so this is the full GSF pig, right? So it's a mere, I forget how many questions, 90 something, 70, 80. Like the request is that every single encounter with every single patient you see in a day, you're supposed to ask yourself if they meet one of these criteria, right? So this is what you're supposed to ask yourself for every single encounter you have in a day. Okay. Probably not going to have legs, right? Like that's a lot to ask of people, to think of that constantly while they're thinking of all sorts of urgent things. So take a step back. Like what would be an ideal system? How would an ideal system work? First of all, accuracy. I don't concede the point that accuracy is irrelevant. I know people will push back and say, well, it's not meant to identify. Well, but the problem is that if you have a lot of false positives, you don't have a lot of time. So you're misallocating resources all the time, right? And people get alert fatigue, right? So code reds, when was the last time any of you did anything, and I mean anything, in response to a code red except close your door and stuff a towel under it so that the noise wouldn't bother you, right? Because we've all heard these code reds forever, and they're never an actual fire. We tend to get, irritating alerts that bug us, and we just dismiss them. We don't look at them anymore. So if you're constantly being prodded and poked to see patients, it becomes an alert that you don't pay attention to. But false negatives aren't good either, right? Because then that leads to untreated suffering. So you do want to try to find a fairly happy medium somewhere between something that's pretty good at picking people up versus not too many false positives. You don't want it to be provider dependent, right? Because something where the answer, if the answer depends on me to fill it out, but if I know if I fill it out a certain way, my workload goes up, chances are I have a pretty good incentive to not fill it out that way, right? And to lower my own workload, especially when I'm overworked. So having automated objective things that are not provider dependent is a big advantage in that context. And then seamless workflow, right? Nobody's looking for more things to do. So having extra checklists, extra processes, this is not something that leads to sustainability of practice, right? So we were able to find a tool which we thought would work for this. So the HOMR tool, Hospital 1 Year Mortality Risk, it was developed by Carl Van Walraven, again, CMAJ right there, Ken. A tool that used administrative data sets to try to identify people who were the risk of mortality in 1 year following a discharge, right? So, and it turns out that using some 12 sort of data points from the discharge summary, the discharge abstract database, was actually extremely accurate at identifying or coming up with a prediction tool that had very high level of accuracy for predicting who was going to die in the following year. So C statistics, for those who are not familiar, you generally get like, a C statistic is also known as a receiver operator curve or area under receiver operator curve. So a coin flip is 0.5, right? So a coin flip that's useless at distinguishing it would be about a 0.5. A perfect predictor would be 1.0. So the numbers always range between 0.5 and 1.0. If it's less than 0.5, then that's weird. But like the surprise question C statistic was kind of in the 0.7 range, high 0.7s. A good test would be in the 0.8 range. And this was at 0.92. And there aren't many diagnostic tests that will get you above that for any conditions. Very, very good, good score. And they actually were able to compare it to other cohorts around the world, other parts of Canada and the US. So it had some data elements that were not available at the time of admission. So we developed a modified version of it called HOMR, modified HOMR. And then subsequently, Carl Van Walraven and Alan Forster developed a newer version of it called HOMR Now. Exclamation mark is very important. And it was adapted for use in a prospective way so that you would only use data that was present at the time of admission. And it remains very, very highly accurate. I don't need to get too deeply into this, and I'm sorry the font is small, but just to show you some of the data fields that are in these tools. So it's simple things: age, sex, did the person come in on home oxygen, what was their admitting diagnosis, Charlson Comorbidity Index if they have it, what's the admitting service, was it a readmission, how many times have they been to the emergency department in the past 12 months, how many times they came by ambulance, where they came from, was it home or long-term care, how urgent was the admission, and whether they went directly to the ICU. So it turns out that if you take out these were the 3 data points that weren't available at the time of admission. So just using that, we barely lost any accuracy at all. So we just used that in our initial work. But then with the HOMR Now tool, they were able to say, even if you got a Charlson score from a previous admission, it would be in the system. You can just pull that, and the computer can just pull it automatically. And then other things like, were they seen in the cancer clinic? And again, they were actually able to integrate something called the LAPS score, which is using lab values and extremity of lab values to also help tier it. But it's interesting that, in fact, that's the only acute clinical information in any of these models, right? Because it turns out that, of course, the most important factors relate to fairly obvious big ticket items like age and comorbidities and where you came from. So if you're 85 years old, coming in, you've come to the hospital 6 times in the past year, and you live in a long-term care facility, it doesn't really matter if you have cancer, heart failure, Alzheimer's disease, your mortality risk is high, right? You're very likely to be in the final year of your life. So in fact, just using simple data points in the administrative database can be really helpful for flagging individuals who may be at elevated risk. So we went and did a feasibility study to see if it was helpful for identifying people and really how that would play out in a hospital environment. So we did a lot of fetching about, where we should put the cut point, right? So you get a continuous score, and then you have to decide, okay, on that score, above what score would you flag somebody as being at elevated risk versus at not elevated risk? And did we go for the most accurate? It turns out that the most important consideration for people, turns out, is actually workload. So rather than go for the highest combination of sensitivity and specificity, we went for a more specific, less sensitive threshold, because then we wouldn't overwhelm the teams, right? That it's the availability of the receptor, if you will, that's the most important consideration. So we put a specificity of 90%, so a really good positive likelihood ratio of almost 6. And if it's negative, well, you don't get a notification, don't worry. And it flagged something like 10, 12, 15% of all admissions coming in. So it's about 10 to 15% of people coming in would get flagged on the medicine wards, but not more than that. Notably, 89, 90% survive to discharge. So the last thing you want to do is build this really fancy system that flags people when they're 2 hours from death. That's not that helpful. But you're flagging people, most of whom are going to survive to discharge. So you have an opportunity to intervene and possibly, screen, identify palliative needs, meet them, and then come up with a new plan that will change their future, which is good. Again, the only lesson we learned from this was don't use email. Nobody likes email. If you can integrate it into the EMR, that's great. Amazingly high support from patients. We were worried people might get afraid that, Big Brother was searching their chart and telling them they're going to die. In fact, patients really were like, yeah, anything that makes the doctor talk to me is a good thing. And so they were quite supportive. So this is what it would look like, when we actually started flagging people, right? So what we did was we used the tool to flag individuals, and then we sent a research person in to simply administer an ESAS, right? A sort of a 9-item screening tool of symptoms. And then we asked them about an advanced care plan. So there's one item of Rebecca Sidore's ACP engagement tool. How ready are you to have a conversation about the kind of care you would want if you were sick and couldn't speak for yourself? Simple. So just 10 questions. Amazingly high response rates. People did not scream and send them out of the room. That basically didn't happen. And interestingly, so these were the people who got identified, right? So where we're already pretty good at flagging patients with cancer, this was very good at flagging patients with organ failure, but particularly with frailty. And then when we looked here on this axis, the y-axis, this is the proportion of people in each trajectory who had unmet needs. Right. So you can see unmet need was defined as having 1 or more symptoms higher than 6 on the screening tool, so in the severe range, or wanting to talk to a physician about their care. So again, you're walking in the room, you're flagging people, you're particularly good at flagging people who don't normally get flagged, don't get noticed by the team. And the vast majority, overwhelming majority of them are going to have an unmet need that you actually might be able to do something about, which is good. And again, if you look, here's the sort of wall balls approach to how this might play out. So let's just look at this cutoff point here. So, for every 100 admissions to GIM, right, if you're looking at just the top 10%, of the 100 people that come in, you're flagging this many people, approximately, based on the modeling that we did. That group accounts for 60% of the mortality in this entire group. And of these people that you flag, this many purple have both a severe symptom and a desire to talk about advanced care planning. This many people have a desire to talk about advanced care planning. This many people has a severe symptom. Only one would have neither a severe symptom nor a desire to talk. So again, small amount of time, very high yield. Okay, this is likely to be the heavy burden of unmet palliative needs in your group, right? But you're not talking to everybody. You're not going everything for everyone. You're just focusing on the highest yield areas. So we went across and we went from there to try to build an implementation project, and we were very fortunate to get that funded by CIHR and Healthcare Excellence Canada to scale it up and start to roll it out at hospitals across the province and evaluate to see whether it helps identify unmet needs and change and looking at successful implementation. So we're ultimately naturally we started it at exactly the right time to start any very large QI intervention, which was January 2020. Okay. Yeah. Anyway, so COVID was obviously an international conspiracy to mess up my career. Yeah, so again, it's been a slower process than we had hoped, but we have gotten it rolled out at, I think we're up to 10 hospitals now. We didn't quite get to 12 for the CIHR project. We're well beyond that outside of the project as well. So all new patients were admitted. We did a tailored implementation. So we helped build a team within each hospital, change management team, driver diagrams, clinical leads, information leads and stuff. And all we got them to do was use the HOMR tool, integrate it into their EMR, and got it to drive screening for unmet symptoms using the ESAS and a 4-item advanced care planning readiness tool. We later shrunk that to just the one question. There's 4 questions, but the only one we really cared about was how ready they were to talk to a physician about their care in the future. And again, that was they were connected, and we didn't actually mandate any specific intervention. It was meant to just bring it to the attention of the MRP teams, and they were allowed to manage that however they wanted. There's a pragmatic reason for that, is that everybody was in a different place in their hospitals in terms of what they could actually deliver, and doing the whole arc of both detection, identification, and deployment of a response, we felt was too much to try to do in one project. That let's just get the signaling right first, and then we'll take it from there. For those of you familiar with Epic, this is kind of what it looks like. So it was built as a best practice advisory, a BPA. It's called a nested BPA. So when HOMR identifies somebody like this, it would send this prompt, and the nurse taking care, it gets scheduled as an event, and they'll go and screen. And you give verbiage if the nurse is not comfortable asking these questions. It actually tells you how you might ask the question. Because you're ill in a hospital, we'd like to ask you some questions about your symptoms and about planning for what's ahead. And again, this was just trimmed down to how ready are you to talk to your doctor about the kind of medical care you would want if you were very sick or near the end of life. And then the ESAS. And again, verbiage. The next questions are about symptoms. Please indicate the number that best describes how you feel now, right? So it's just a simple adaptation. The data that collected then gets fed into another BPA, best practice advisory, that gets fed to the MRP team, right? So it's in the patient's file and it flags on their storyboard on the left and it'll pop up for them. So the flag says, you know, this person is at elevated risk. Please consider whether they have unmet needs, such as uncontrolled symptoms, et cetera. And it will give you their ESAS scores. So you can actually see exactly what the issues are. And it also tells you how ready they are to talk about advanced care planning. So it doesn't just say, Mr. Smith might die. It says, Mr. Smith has these unmet palliative needs. Just letting you know. Right. So you actually know in most cases, you're going to walk in, like if they're telling you they're ready to talk about advanced care planning, you know, you're going to be met by somebody who's probably pretty receptive, right? You know what kind of reception you're going to get. If you feel comfortable managing it, and if you don't, then obviously you can contact somebody else. And we put in a link, you'll be happy to know, Justin, to the serious illness conversation. You're embedded there. Yes, there you go. So it's everything feeds everything, right? So we did a pre and a post. So we asked people to collect data, like the HOMR would just work in the background, flagging patients, and then we would see what care they got. And then on given date go, you would then start getting these notifications. And so they're essentially supposed to be comparable patients before and after, just to look at the kind of care that they received. And I'll just take you through some of the highlights. We don't have all the data yet, but some of the in-hospital data is quite interesting. So again, who's getting identified? Predominantly elderly individuals, again, 50-50 men and women. It's pre on the left, post on the right. These patients shouldn't look different. And they do a little bit, but not in a meaningful way. Again, predominantly you're flagging people with frailty and organ failure, less so patients with cancer. These are patients with cancer are patients that we're usually pretty good at flagging anyway, so it's not a huge loss. When we looked at any documented assessment of symptoms, that went out quite dramatically and significantly. A completed ESAS assessment, it went from 3% to almost 50%. Identifying patients with severe symptoms went from 4 to 187. So, you know, a very substantial, almost 30% in this cohort had a severe symptom that was never documented previously in the chart. Full assessments of advanced care planning readiness and including tools. This also went up quite significantly. And again, what you're finding in general is that the patients who are like really, you know, there's a lot of people who are ready, like they're ready to talk about it or they feel like they've done it. The number who are refusing is exceedingly low, right? So again, the patients that you're flagging, these tend to be patients who are pretty ready to have this conversation. So then in terms of interventions, now mind you, we did not mandate any interventions. They're like, just bringing it to the attention of the team. They can do what they want. Okay, so obviously any kind of documented goals of care discussion went up, right? So and the bar was pretty low for that, but it did go up significantly. Notably, people didn't just immediately call palliative care teams, right? So palliative care services were worried this would be just a flood of consults. Didn't happen, right? Teams often felt competent to manage this stuff themselves. There was a significant, there was a change in discharge with palliative home care, but we'll show where that went. This is, of course, probably confounded by the COVID pandemic. But small numbers, but significant reduction in patients intubated as a result of this. Now, in terms of discharge destination, we had a significant reduction in patients who died in hospital ultimately, and an increase in those who went to what's classed as complex care. In most cases, this was actually a palliative care unit funded as complex care. So there was more patients being diverted away from either they were getting out of the hospital to palliative care settings more as a result of this notification. And again, we didn't mandate anything, but it was just bringing people attention and flagging these unmet needs that became important. So in terms of identification and assessment, which is what we really wanted, we saw quite a dramatic improvement in patients being identified and teams being made aware of unmet palliative needs, right? So this is the substrate upon which you can start to hang your interventions, and it's done in a very reliable way, obviously. We did a lot of implementation studies, and I don't want to go into that in great detail because I don't want to run out of time. I think we need time for questions as well. But again, we did a lot of implementation interviews with project managers, nurses, physicians. Obviously, barriers, the pandemic, increased workloads and patient demographics. We'll talk about what that means. Facilitators, obviously, a motivated workplace culture and a desire to innovate, right? So when you have people who are sort of motivated and keen to try new things, that's a real success factor for a project like this. Obviously, trying to do this through COVID, there were staffing shortages, there was burnout, right? And like increased workloads, like, oh crap, all these alerts keep coming up. What are we doing? Like your phone's going off, you're busy doing other things. It's hard. Quality improvement projects always suffer from this, right? You're always going to run into problems like this. And then the cultural concerns that some of the hospitals were in areas where a large proportion of immigrants and people from cultures where palliative care, advanced care planning are not familiar concepts, right? And so it can be quite resisted. And they found it was a little bit, difficult sometimes if they were being pushed to talk to people that they didn't feel were ready to be talked with. So. But again, the facilitators, like people were really flagged that like actually it sustained, it seemed to work. And you'd get a few early successes or few obvious examples of when it worked. And that really sustained the project. Like people really ran with it. And people felt that it really aligned with the values that they were in medicine and in nursing or whatever to promote. So that was obviously a helpful facilitator. So conclusions, it was effective for improving documentation, identification of palliative needs. And it was complementary to judgment, right? So it didn't force you to do anything. It just brought something to your attention, right? Like if there may be very good reasons you would not talk to somebody and you may not want to talk to certain individuals, even if they're flagged, that's fine. The computer doesn't force you to do anything. The computer doesn't circumvent you to go to families. It nudges, it prompts you, right? And in fact, we saw pretty high completion rates, in terms of people following it. It was like 60-70%, which is a pretty good number for a QI project. So in conclusion, I just want to really thank all the sites, obviously, who were involved in helping us implement that project. It was a really exciting experience for us. It was a learning experience, and now we've been very fortunate because we've been able to go out. There's now HOMR is being integrated into a couple of sites in the UK. There's a site in the south of France that's doing it. It's Italy. These are all wine producing regions that have yet to actually invite us in person, but we're hopeful that will happen at some point. In BC as well is interested in it. So it's the kind of project that, and of course Harvard, is very interested to look at this model as well. So we've got some plans to integrate with them. So again, I think that we're seeing more and more. There are other sort of similar projects afoot, like using AI models to flag individuals. I think this is all the way of the future, like as we think about it. So it's really exciting to be a part of this sort of transition as we move to palliative care 2.0, 3.0, whatever you want to call it, but how we use these tools. But a big thanks to all the funders. And again, I'll just leave the QR codes if you want to see the website. And a big thanks to Julie Lipensky, who's my research manager / director now. And she's been heavily involved in helping this project succeed as well and been really leading it. And of course, big props to Pete Weeger, who was my co-lead as well, and Sarah Subramaniam, who was working, and both of them are at Humber River in Toronto. So thank you very much.
Wow. Thank you so much, James. This is extraordinary work. And to your point about the using AI to get just a little bit better. I mean, it's extraordinary what we have with a relatively simple tool. I'm going to moderate some questions if that's okay. Maybe I'll stand here. You can stand by the mic so people can hear you. And before I do that, thank you. So I just want people to be aware, the Serious Illness Conversation Guide is a tool that's been studied in many healthcare systems and implemented. And we currently have an alert now in OASIS, an alert document in OASIS with the Serious Illness Conversation Guide template. And so I encourage people to check that out because it is arguably as useful as a level of intervention form, perhaps more so. And so I encourage people to check that out. Okay, so we have a question from the audience. Could an approach like this help limit futile care in the ICU?
Yeah, so a great question. And again, the challenge, right, is that there's how one defines futility. This is a whole other 2-hour talk, but how one defines futility, et cetera. There's getting around that issue. We did find that there were fewer people intubated as a result in this one intervention. But we're keeping in mind, HOMR was simply helping you identify individuals, right? Now, part of the problem is there's a little bit of a self-fulfilling prophecy around mortality prediction sometimes, right? Where it's people were like, well, aren't you going to, retest it and revalidate the mortality model? It's like, well, no, because we're going and telling people to talk about goals of care and symptom management. I mean, the whole point is that, life prolonging care can sometimes prolong life, right? So the idea is that if you don't do life prolonging care, it stands to reason that people might not live as long. But the question is that not consistent with their goals, et cetera? So I would say the answer is it probably will, but it's almost impossible. Like, did we avoid, like, was it futile because we said it was futile? Or like, did we avoid potentially beneficial long ICU care, or potentially totally physiologically futile ICU care? And there's just no way, you can't know the counterfactual for a study like this. So it's a great question. It is philosophically and epidemiologically unanswerable. But I think that the point here is that what I would like to convey is the purpose of a tool like this is not to get everyone, to stop people from going to the ICU, to stop people from getting chemodialysis. All of these things may be totally appropriate, right? Like for individuals, for all sorts of reasons, palliative chemo, palliative rads. We put people on non-invasive ventilation even when they have incurable end-stage COPD. That's not wrong to do that. But what it does do is, I think a lot of us have the perception that there's a good chunk, 20, 30% of people that end up going to the ICU, dying in the ICU, who really never wanted to be there in the first place. Like, you had somebody simply spoken to them a little bit earlier. And it's not like 100% going down to 0. It's like 50% going down to 20%. And I think it's these, like, HOMR is about pushing open doors, pushing doors that are already half open, right? Like, you're not trying to force people, compel people, get in fights. I always tell people, if you encounter resistance, slowly back away, make sure you have a path to the door, walk out of the room. That's not the point of HOMR, is to pick fights. The point of HOMR is to identify the very substantial proportion of people that want to have this conversation. And the only reason it isn't happening is because nobody started it with them.
Thank you. Stephanie, and then Joyce.
Is there a microphone for me, or?
If you go ahead, we'll repeat the question.
Okay. Interesting about that is, when I was involved earlier, 2 years ago, in something that was similar to that, it was really to identify patients that we could see in our clinic, because we couldn't see everyone.
Yeah.
Right. So let's target people that would benefit the most. What I like about this is you're targeting patients for colleagues outside, right? Colleagues in the hospital. So how do you know, or did you train, or do you think people need training, like all clinicians, nurses, everyone that's going to be in contact with the patient, to use the serious illness conversation, right?
Yes. The short answer is he should definitely do all of that personally. I strongly support Justin doing that work instead of me. No, what I'm saying is, so I started life as an educator and did a lot of educational interventions and tried to roll them out and train people. And I got very good feedback on it. Like, everyone seemed to love the workshops, and we did standardized encounters, and the skills went up, and it was all great. And then you go to the ward and nothing happens, right? It's a classic, culture eats training for breakfast. The challenge is that there's just too much of the sort of hidden curriculum that drives us, right? Like, we have a way of doing things in a standardized encounter scenario, and then we have a way of doing things on the ward. Unless you're going to tilt the table, unless you start putting in nudges and other things to actually drive behavior change, skill building is necessary, but not sufficient to change behavior, right? Skill building is critical, and everyone will tell you that. I don't even have to look at Justin, because I know he agrees with this completely. But like, they're complementary, right? So like, you really should be trying to do both of these together in an ideal world, right? You're building the tools and you're building the skills. And part of what we're doing with our Ontario, like our models of care, is the idea that as we're trying to get earlier and more, we're delivering overall the area that the time number area increases. So that can't possibly be delivered by specialists, right? You like, if we're going to do palliative care for more people and do it earlier, the math doesn't math, right? Like, the only way that works is if more people who are not, doesn't say palliative care on their badges, is doing at least some of the palliative care. That means we have to start building those skills, right? So nurses and people at the bedside and champions need to be out there screening and identifying people. We need to be thinking about scalable interventions. We need to be upskilling people to have these conversations. I would posit that you will save a lot of time and money if you do it, right? Because again, all of these people are eventually going to have these conversations, all of them, right? But the difference is doing it in the light of day, in a controlled environment with their family members, versus crisis moment after hours on the weekend, which is what's killing us, right? You're actually going to get better results. And if all of us invest that time, if you invest the time up front, it doesn't have to be done later. So you're saving either yourself or a colleague down the road. And so if we all buy in and do this, there will be a net massive benefit for the system, for the patients, and for ourselves in terms of workload. That's my feeling. Sure.
Thank you.
So thanks very much. This is just a practical question. So the way the trigger works, that you're doing it, is that right?
So you could have it done many ways. Sorry, I should have explained that better. Different hospitals work differently about how they can do this. And in fact, the obvious split often is with community hospitals versus academic hospitals. So academic hospitals, there's a lot of turnover. Like every month, it's a different person. We're training new people. So having EMRs, having a notification that goes directly through the EMR is kind of helpful. But there are some of the like medium-sized community hospitals that actually had a much better system to work with HOMR, which is that they would have champion models. So like you'd have a team with like a doc and a nurse practitioner or a nurse, and the nurse's jobs, for example, would be to go and like troll the emergency room in the morning to see if there's anything that came in, check this, check that, or they go sit in on bullet rounds on the medicine wards and whatever. So they'll spend an hour listening to hear, magic words that would cue them into a patient that they might want to go and see. I'm saying, stop doing that. Don't walk through emerge in the morning. I'm going to give you back that time. I'm going to give you back your time in bullet rounds. You walk in the morning, the computer spits out a list of people who came in the past 24 hours who are flagged by HOMR. And all you do is you just go and see them with an ESAS or whatever, you screen, and you, by the time like that 1 hour that I gave you back is done, you've seen, assessed, and possibly even come up with, and talk to the MRP teams of all the patients that you would have gotten through that process anyway. So I've given you back net time, you've already done all the work, and it really helps. So the champion model, like we sort of have the distributed model and the champion model. The champion model is exceptionally good for HOMR. The distributed model is probably not as effective as the champion model. Whether champion models can be put into larger academic hospitals, that might be good for the way of the future. But again, as we build up skills, that's different. Yeah.
That wasn't my question.
Oh, sorry.
So my question was, how much of the time was it difficult or impossible to have the question because the patient was demented, or the patient didn't speak English or French?
So good. That's a good question. So, okay, thank you. There's, if I recall correctly from the pilot work, because you can indicate whether it was the patient or a substitute decision maker that had the conversations. And so obviously the ESAS, you are allowed to do a surrogate ESAS. It's not ideal, but again, yeah, it would be, I think about a third of the time it was a surrogate, and 2/3 of the time it would be the patient. But I mean, that's a bit of a misleading. So like the total number of screens, the total number of flags that got screened was about 60% and we didn't incentivize this. They just did it like 60+% time, which was like really good. Yeah.
Yes, a surrogate.
Yeah.
And you talking about extra time, right?
Yes.
Now you've got to find a family member because the patient is deaf or demented or doesn't speak, whatever. And then it's just less likely to happen.
And you're absolutely right. I mean, part of this ultimately feeding it into a QI or quality assurance process would be the next step, right? So one of the big problems in palliative care is when we try to determine delivery, like end of life care delivered, et cetera. But it's always done retrospectively. And you're like, you know what? Damn it, too many people are dying in the ICU. We should just not do that and just tell everybody be careful about that stuff. But it's all retrospective versus having a population identified in advance that you can track and you can measure quality indicators for once you got the notification. Have we got a documented goals of care discussion? How often are the flagged patients getting actually screened, getting documented goals of care discussion? These are the highest risk patients in your unit. So you've really, that's where you want to start to spend your energy, and you can do audits and feedback and help to drive the quality in the right direction in real time with specific nudges. So I'd say, there are 100 reasons why it wouldn't happen, and they exist. HOMR doesn't address many of those, but it helps you decide where you want to focus your attention. And it did happen fairly often, that people were still responding to cues knowing that they had to talk to the surrogate.
Thank you.
Yes.
Thank you very much. Fantastic presentation. I'm a heart failure cardiologist, and often it's not so much end of life that we're talking about. Sometimes it's hard to identify, but it's kind of in that shift from really active care to more supportive care.
Right.
And I'm wondering, if you have any comments about that, sort of the supportive care, because it could be
yeah.
6 months, a year.
Oh, and longer than that,
Yeah.
for sure, right? So again, you get into questions around, there are many people for whom, you maybe want to make a bit of a limitation on how aggressive you might want to be. But there may be other situations where, simple things like, okay, well, I'd like to turn off my ICD. All right. Keep your, that would be a simple intervention for somebody in that sense. Is this a time when maybe we back off a little bit, aren't so aggressive on the diabetes targets. We aren't so aggressive on the hypertension targets. We aren't so, but you don't want to, don't immediately stop the Lasix and the beta blockers, which everyone seems to want to do. That's a really bad idea. Because, palliative management of heart failure is very similar to standard medical management of heart failure in a lot of ways. But I think a lot of it is about also making people aware of alternative pathways. It's like, okay, heart failure patients are very commonly coming in, and understanding that there may be alternatives. And so we can set up palliative care plans. So maybe they don't use the emergency room. They're sort of responding more with their palliative team at home, or maybe going to a clinic and that sort of thing, and having their exacerbations managed that way. Perhaps that's the moment where people will start to use opioids, right, to help manage, which opioids are excellent medications for heart failure in general. But I think a hesitation among a lot of people to use them. This becomes the permission to use them. So sometimes in the non-cancer model, the transition can be a little subtle, but it's more about, I think, awareness, readiness, and maybe being frank and understanding about the next exacerbation. What's that going to look like? What are we going to do in response to that? But it's not just the emergency room cycle.
And I would just to add, I think, if I may, it's always surprising that we wait until people are near the end of their life before asking them what matters most to them, right? And I think this is an opportunity, certainly a trigger potentially earlier on, to say, tell us about what's most important to you, and use that to guide their care. Marie-Claire.
The initial part of that, I did that living to discharge. Did people in hospital or flagged, but was there any flagging that happened to this?
So not in this project. There were some hospitals and community that did this. They were working on the discharge flagging systems, and trying to put it in the discharge summaries so that GPs were aware. Again, there's no reason, this tool could trigger anything. It doesn't even have to trigger stuff in the hospital. So some hospitals were looking at it as, okay, we'll trigger you, because the model is validated for use at the moment of admission, but it can trigger stuff at the GP. If you have a good relationship with your GP and the GP would rather do the follow-up at home, you can do that.
Well, and the hospitals that did the offload.
Yeah. I think it's important to, whatever you do, to make sure that's meshed. So part of our models of care work in Ontario is we're gonna try to peel the onion of electronic records that cross settings. I know, scary, but I mean that's what we got to do, right? That's the point. So things like HOMR, and there are models that work in, there's similar models that work in long-term care and in home care called Respect, that can help flag people at risk using data in the system. And again, help these prompts. And then you have a sort of common, sort of little tab that you can open. That's the advanced care planning tab, or the care planning, or the palliative tab. And you can see what's been done and what's been discussed, so that you can try to get some degree of continuity if they're going to different hospitals, or if they're being cared for by different people. I did want to just do a quick follow-up to that. What matters most conversation. So I always want to do this study. If you want to do this study with me, it's a really good medical student study, by the way, if there's any medical students who want to do this project. It's the pre-post, I want to do a pre-post urine osmolarity study of family meetings in the CCU. So how many times you see somebody with refractory heart failure that they're in there, they come in, press isotopes, they're not diuresing, it's terrible. We have the family meeting, we agree, comfort measures, everything. Patient takes a deep breath and sighs. It's all quiet, because of course ADH is a stress hormone, right? So if they're calm, right, and then they shut down the ADH and start peeing like crazy, and all of a sudden they diurese, and then the next day, all of a sudden the diuretics are working, the creatinine comes back down. So I wouldn't be surprised if the serious illness conversations more often than not actually improve renal perfusion and make your diuretics more effective. That's the study. It's very simple. You just collect some pee before the family meeting, collect some pee after the family meeting. who could possibly object to that? Anyway, it'll be in the Christmas BMJ edition, I'm sure.
There's another question online, but I'm going to take the prerogative and ask a question about how, you talked about fancy things like Epic, which, maybe at the later part of this decade we'll have Epic. It seems like we will. But my question is like, with all the experience that you've acquired to date, like what can we do now? We have an electronic health record that, barely qualifies as such, sort of a document record
It's
system.
electronic.
It is electronic. It does keep records. But beyond that, it doesn't do much. And so I guess I'm curious, it doesn't calculate scores automatically. It would be hard to find scores if they were documented somewhere. Is there anything that we can be doing now to build for the future of this? And what would that look like?
Right. So one of the key things to understand about HOMR is that the IT component of this is just possibly the simplest part of all. It's actually not the biggest issue here. So the HOMR 1.0, when we did the initial work, was all just based on ADT software, like admission and discharge triage software, which is common to every hospital. And it used HL7 outputs, which are like the simple basic language that every hospital uses. So at TGH in Toronto, it was just on QuadraMed. And not even on QuadraMed. And all we just had was what's called a timer bean. So at 8 a.m. every day, it would just take the ADT outputs for everybody who'd been admitted and ran it that way. You have a data warehouse that stores this in-house. It's very easy to build. And you don't, this is all done pre-Epic, pre-everything, right? So you could get a simple version of it. Now, again, problem is then that just comes out as a list to like one person, right? Then you have to come up with a system. The challenge with HOMR is not really a technical one. It's how you get HOMR to work with the humans, right? And how does HOMR change the behavior or the notification come to the frontline providers? And if you have an interested champion model, and what we would do in the initial stages is we would just have a list that would come to like champions on the medicine ward. We were just going on medicine wards that were really eager to do it and just start there and build out. And that was a simple way to do it, right? Because the HOMR alerts can come for anybody. They can just get ignored if they're off the wards that you're interested in, and just start there and build. So it's actually quite a simple thing to do.
Okay, that's very helpful. That's good to know. I hope Alan Forster's on the call, because
Alan was involved in every iteration of HOMR and was really instrumental in helping us build this. Hey, Alan, if you're listening, and was extremely supportive, big success factor in Ottawa and everywhere. And of course, he and Carl were the ones that went out and built HOMR Now for this purpose, basically.
So there's one question that comes in, and it's I'm curious how you think about this as a person who's talked a lot about MAID. And the question is, are we identifying patients, a portion of whom may be interested in MAID, and what is how do you even think about that in relation to what you've talked about today?
Yeah, I often get asked about that. And again, I think there's a lot of sort of ethical questions around that. It's like, do we, the idea of who brings up the question of MAID, should it be something that we wait and wait for the patient and the provider to ask? Is it something that we ask? I think a lot of that depends on your moral or normative view about MAID, right? There's some people who think that, are really uncomfortable with the idea of MAID and really uncomfortable with MAID happening except in exceptional circumstances. And the counter position, of course, that, ultimately ignorance is not a safeguard, right? Like, I mean, if there are just many people who want MAID, would have wanted MAID, but aren't getting it because they weren't even aware of it. So is the fact that they're not getting MAID a success? And if they get MAID, is that a failure simply because we brought it up, but that's what they would have wanted? I think we're very much as a society, coming to terms with this concept. And I think that's a sort of a moral, ethical question that goes beyond the use of the term. I think it really depends on what you think. I mean, for a counterpoint though, just to remember, it wasn't that long ago. And I mean, when this guy was in training and early staffhood, where, and we still get this all the time, where oncologists are just like, it's not time to talk about palliative care. They don't want us to bring up palliative care. They will tell us, I don't want you to talk about end of life stuff. I just want you to focus on the pain control. And they're very deeply uncomfortable with the concept of palliative care being raised. And, even 15, 20 years ago, I would say that was a routine thing where they would just say, they're oncologists, they don't refer to palliative care because palliative care is going to talk them out of chemo, right? And make them give up. And, that's not the purpose of medicine. That's what they said. Then they would say it openly to your face, right? And that was not even a generation ago. So we continue to address this issue. I'm so grateful to the Department of Medicine for allowing us to bring James from all the way from sunny Ottawa. I'm so grateful to you being here today and sharing this with us, this extraordinary expertise that you've accumulated over the years. And I hope we get to have you back very soon. So thanks everybody for being here. That was fun.